Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing hemophilia, a rare disorder that weakens the blood's normal ability to clot. We'll dive into what causes hemophilia, who it affects, and what it's like to live with this lifelong condition. We'll also touch on some exciting new developments in the treatment of hemophilia. Joining us to help us shed light on this rare but serious disorder is Dr. Suchitra Acharya. Dr. Acharya is a pediatric hematologist oncologist and the director of the Hemostasis and Thrombosis Center at Long Island Jewish Medical Center. She's also the head of the Bleeding Disorders and Thrombosis program at Cohen Children's Medical Center and a professor of pediatrics at the Zucker School of Medicine at Hofstra, Northwell. We're also fortunate to have two teenage patients of Dr. Acharya, Evan and Milo Cedeno, both of whom have hemophilia, to share their personal experience with this condition. Suchitra, Evan, Milo, welcome to Well Said.
Thank you, Ira, for this opportunity, and thank you, Milo and Evan, for being on this radio show. And thanks to the Well Said team for coordinating this. I really appreciate it.
Well, it's my pleasure. Suchitra, let's start with you. Most people understand that hemophilia has something to do with a malfunction of the normal clotting mechanism of blood. Can you tell us a little bit about how clotting normally occurs and why it's so important?
Blood clotting is a complex process that prevents prolonged bleeding, which, as you can imagine, could be harmful to the body. It's a well-orchestrated process which occurs with the help of cells called platelets, and there are about 13 different proteins which we refer to as clotting factors. They're essentially proteins, but we call them clotting factors. When blood clots appropriately, it changes the consistency from liquid to solid at the site of injury. Blood has red cells, white cells, platelets, and clotting factors flowing in the liquid component of blood, which we call plasma, present in the blood vessels. Whenever there's injury to a blood vessel, the first step is to reduce loss of blood by narrowing of the blood vessel, followed by a rush of platelets to the site of injury, forming a temporary plug to stop the bleeding and close this area of injury. There's also release of a protein called tissue factor, which activates a chemical reaction resulting in the formation of a fibrin clot. Fibrin is a strong strand-like material which enmeshes into the platelet plug that's already formed, keeping it firm and stable. Over the next several days, the healing process begins by clot strengthening and clot dissolution, and all is back on track. We need normal levels of clotting factors to form a strong clot to prevent bleeding. When clotting proteins or these clotting factors are not produced at all or produced in low levels, it puts an individual at risk for spontaneous trauma or surgery-related bleeding, which could be excessive or uncontrolled.
So just to simplify a little bit what you just said, we've got all of this stuff circulating in our blood all the time. When there's an injury, the platelets form a plug, these proteins get activated, and they kind of stabilize the platelet clot and then allow the body to heal and restore what was present before.
Yes, that's
okay.
Correct.
Briefly, what is hemophilia then, and how does it relate to that kind of normal situation that you outlined for us a minute ago?
So in hemophilia, the formation of this fibrin clot is limited, and therefore oozing is a common problem because, as you can imagine, the blood vessel barrier is broken, and you can't form a clot to stop that, to heal the blood vessel. And so I would say hemophilia is an inherited bleeding disorder which runs in families as a result of not making adequate amounts of these clotting factors. And we refer to two different clotting proteins, factor VIII and factor IX deficiencies, as hemophilia A and hemophilia B respectively. So both these disorders would result in blood clotting less or taking a long time to clot, therefore putting an individual at risk for prolonged bleeding. And I just also want to point out that individuals with hemophilia do not bleed faster than those without hemophilia, but do bleed for a very long time.
So it's not that they bleed more excessively at the start, it's just that they can't stop it normally.
Correct.
Is that what you're saying?
Yes.
Okay. And you said that this is a genetic condition. Could you explain how hemophilia is passed down through families, and how common is this?
All proteins in our body are coded by genes, And sometimes what happens is that genes which carry instructions for making normal clotting factors, they could mutate or change. And these mutated genes then give instructions that end up making none to low levels of these clotting factors. But having said that, about 20 to 30% of hemophilia cases could be spontaneous, meaning that there may not be any other individual in the family with hemophilia.
Okay.
Just to give you some numbers, these are rare disorders. About 10 in 100,000 can have hemophilia A, and about 3 in 100,000 can have hemophilia B. So roughly about 400 per year born with hemophilia A and 100 per year born with hemophilia B.
You mentioned boys. So why is this more common in males instead of females?
So the inheritance of hemophilia we describe as X-linked recessive. So just to kind of go over this in a little more depth, each individual receives one set of chromosomes which carry genes from their biological mother and one set from their biological father. If you get an X chromosome from your mother and an X chromosome from your father, you will be a biological female. Mm-hmm. If you get an X chromosome from your mother and a Y chromosome from your father, you will be a biological male. Mm-hmm. So your mother usually will pass on the X chromosome to her children, since females have two X chromosomes. If now the mother has an abnormal clotting factor gene on one of her X chromosomes, she may carry hemophilia, but she may not have symptoms. But because there's a normal clotting factor gene on her second X chromosome, this balances out and she may not have bleeding symptoms. Now, when this mother carrying the hemophilia gene on her X chromosome passes it on to her son, he will have hemophilia, the disorder, because the son has one X and one Y.
So these clotting factors are coded for by the X chromosome.
That's correct.
So if a man has a Y chromosome from his father and an X chromosome from his mother, and the one from the mother has this defect, that's it. He's got the disease.
He's got the disease. That's correct. So every son of a hemophilia carrier mother has a 50% chance of having the disorder, since we cannot predict which X chromosome from the mother carries the hemophilia gene. A daughter of a carrier mother has a 50% chance of being a carrier because, like her mother, the other X chromosome she gets from the father is normal and compensates producing low normal to normal levels of these clotting proteins. And therefore, males are more commonly affected.
Got it. Is there any consequence to being a carrier?
Carriers can be symptomatic. That is, they can have bleeding symptoms, especially after surgery. Some carrier women can have heavy menstrual bleeding, their periods every month. Mm-hmm. So, yes, there is a potential for carriers to be symptomatic.
Yeah. Evan and Milo, I'd like to turn to you now. First, thanks again for coming on the show to share your story. Is there a history of hemophilia in your family?
Yeah, Dr. Ira, thank you so much for having us. We're really excited to be here. And prior to our mother, there is no family history of hemophilia, which means that our mother has the gene mutation for it. And it just so happens that Milo and I both received that X chromosome with the mutation. So we both have severe hemophilia A.
How old were each of you when the diagnosis was made?
My diagnosis happened 2 years after I was born, when Milo was born. So they actually didn't know what I had until my brother was born.
Yeah, okay. My brother was originally born in a different hospital out in Brooklyn. He had the condition for 2 years, and they didn't diagnose him when he was initially born. And it wasn't until I was born at a different hospital at Long Island Jewish where they actually diagnosed me, and after that diagnosed my brother. So he went 2 years undiagnosed having this condition.
Obviously, I don't expect you to remember those first 2 years. Were you told by your family that you were having bleeding problems as a baby or a young child?
Totally, yeah. I know my mother suspected a lot of things. I think, bruising, especially as a kid, playing around, a lot of bruising happening. I remember she would mention I had pain while my shoes were being put on, and they didn't know why I was crying, but they're just trying to put on my shoes.
Yeah. And then what was it about your younger brother's circumstance that tipped people off that this was hemophilia?
Originally, after my brother was born, my mother, of course, was always looking for something. She always thought there was some reason why my brother was bleeding so much more than I was. Originally, she was dismissed, but after I was born and they saw the same sort of complication happening where I was also getting heavy bleeding after I was born, they then decided, hey, this is actually something we should look into. And after being at a different hospital, they were finally like, hey, this might be hemophilia, and they tested us.
Suchitra, is that a typical story where it can go on for some time, kind of maybe there's parental concern, maybe not. It's not immediately recognized. What's the typical story for the discovery of somebody having hemophilia?
That's quite common, I would say, especially in the newborn period. So we see patients and they come to attention a lot of times when they are circumcised at birth, because somebody with severe hemophilia will have significant bleeding at birth, becoming anemic, requiring a blood transfusion at times.
Wow.
Sometimes when giving immunizations, because when vaccines are given into the muscle, it could cause a muscle bleed. I've seen a couple of patients, present with bleeding into the muscle with pain and swelling of the muscle, and that's how they come to attention. So I'm not surprised with Evan and Milo, how the diagnosis was made at the time when they were diagnosed. As kids grow older, they become more mobile. They start having bruises, which are like bumps because you bleed longer into the skin, under the skin. And so they felt like bumps, and they're not flat like regular bruises. And some astute pediatricians have actually picked this up and referred patients to me. So that's another way of presentation. Once they start crawling and walking, they could fall several times and have butt bleeds because they fall on their butts. Typically, once they start walking and running, they can have bleeds into their ankles, which present as pain and swelling, and that's what I think Evan had early on, which wasn't, recognized. So typically, you can have pain, swelling in your ankles, knees, and elbows, which are the most common joints affected by hemophilia with bleeding into those joints, but it can affect any joint.
That would suggest that all of us are having small amount of bleeding into our joints as children, but the bleeding stops, whereas in these cases, that small amount of bleeding turns into a lot of bleeding. Is that a correct way to look at this?
Yeah, because in a hemophilia patient, any kind of minor trauma, you will bleed, but then you don't clot, right, to stop that bleeding.
Yeah.
Because of that, it accumulates inside the joint. It goes into the surrounding soft tissue sometimes, and it's extremely painful, and the joint is swollen. And unless and until it's treated right away, the symptoms don't resolve.
If there is suspicion, as there was in Evan and Milo's case, that, hey, maybe these little kids have hemophilia, what tests are done to actually make the diagnosis or confirm the diagnosis?
So the first thing we start with is a history, right? Since it's X-linked recessive, which means it's on the mother's side of the family, we ask about a bleeding history in a maternal uncle or maternal grandfather or any other individual on the mother's side, especially males who may have gone to surgery and bled after surgery requiring a transfusion. So we start off by doing the screening tests called prothrombin time and activated partial thromboplastin time, or PT and APTT. In hemophilia, the APTT test is abnormal, and once that comes out abnormal, we send specific clotting factor levels, the factor 8 or factor 9, based on the symptoms that we've gathered from the history. And once those come back, abnormal or extremely low or undetectable, we send genetic testing to confirm the diagnosis. And genetic testing has other implications to screen other individuals, especially carrier females in the family,
So you can actually measure the level of these proteins in the blood and determine that if they're dramatically lower than normal, that kind of makes the diagnosis.
Yes, absolutely.
Evan and Milo, I want to turn back to you again. We're just talking about all sorts of problems that young kids can have with hemophilia, and I'm assuming that's before it's brought under control or adequately treated. Joint problems, bruising, swelling. Which of those things, if any, did you encounter as young children?
Milo and my condition differ a little bit. Milo will share his perspective, but for me growing up, I think just in general, our parents were really concerned and knew our limitations early on once we were diagnosed. And so a lot of our childhood was preventative. We took certain measures to prevent injury, but of course it happens. We're kids. A big part of growing up is playing outside, being with friends. And so, bleeding definitely occurred more so in the joints than anything else. That was a big thing. I have a target right ankle. That's something that's bled a lot over the years, and it's a target joint, which means that it's more susceptible to bleeding now because it's bled in the past. Bleeding's definitely a problem, but, growing up, Milo and I, we knew our limitations. Although it's hard for us, we do try to find ways that we can exercise our passions, learning to turn our, her unfettered energy of young boys into intellectual stimulus. And so we've grown to find a plethora of different activities that we really enjoy that involve, like origami and Rubik's Cubes and engineering. We both want to be engineers now. And so we've definitely found ways to navigate our condition, but bleeding is something that could always occur, and it's always on our minds. It's on our radar.
You said something about preventive measures. I'm struggling to imagine how to keep toddlers from, running around and bumping into things, short of like wrapping them in bubble wrap. I mean, what did your parents try to do to minimize the chance of injury for the two of you guys?
We didn't see the playground too much, unfortunately, just because it's a very, I don't want to say volatile, but more of a chaotic environment for little children when you think about it. I remember when I was in kindergarten, I still wanted to go out to recess. My mother bought me this leather, sort of like a baseball cap. It was like completely leather, and I had to wear it. It like fit over my entire head so that if I fell down, like I wouldn't injure or crack my head open. That would have definitely led to some extremely severe bleeding.
Right.
It definitely sort of changed our outlook on life. We were always different because my condition is not as well contained or as well treated as my brother's. I actually had a paraprofessional, which is essentially just an adult who followed me around until I was in 5th grade.
You had a watcher, somebody watching you and kind of keeping you out of trouble?
Yeah, absolutely. For my entire elementary school career, I had someone who sat by me whenever I was anywhere. They followed me everywhere around school.
Wow.
I had to sit in the back of the classroom because the para didn't want to sit in the front to block the people's views. So it was definitely an interesting experience. I can't say it was, the best, but
no, I can imagine that must have been fairly traumatizing by itself.
Yeah, it definitely was. Looking back on it, my parents were just trying to do what they thought was best for me. And, I'm not mad at them at all for it. They were just protecting me. And, that's sort of what you have to do when you have a condition like this.
Both of you mentioned that your conditions are somewhat different from one another. Could you say a little bit more about that?
My brother was diagnosed with severe hemophilia A. And actually, I was diagnosed with severe hemophilia A as well. I developed what's known as an inhibitor, which is antibodies that my body created to fight against the factor, which is typically developed when you're first starting factor treatment. So we are both deficient in the clotting factor 8. And when my brother started, he just supplemented his deficiency by taking factor 8. For my body, when they actually saw factor 8 entering into my body, it was seen as foreign. So my body started attacking it and producing antibodies. So I wasn't able to just supplement my deficiency with factor 8.
Okay.
Which leads to some further complications because obviously you need factor to clot, and clotting is super important.
So before we get into all of that, let me pivot back to Suchitra to talk a little bit about the treatment, since on a certain level, it sounds pretty straightforward. Your body's not making enough of a critical protein, and so we now have the capacity to give people that protein. Like you'd think that that's end of story, but clearly not. So why don't you educate us a little bit about treatment strategies for hemophilia and how that relates to the story that Evan and Milo were just telling us?
As Evan and Milo pointed out, treatment for somebody with severe hemophilia, since severe hemophilia causes bleeding into your joints and muscles. And one of the ways to prevent this bleeding into your joint and muscles is to give factor on a regular basis. So there are two aspects to this. One is treatment of a bleed when you actually have a bleed by treating with factor. And then once you have a joint bleed, we usually adopt a strategy called prophylaxis, which is preventative treatment to prevent bleeds into the joints and muscles. Preventative treatment, factor product, so that everyone has an idea. It is administered intravenously, that is into the vein, and which sometimes can be, burdensome for very young children. But a lot of families are taught how to infuse their kids, and eventually once they are adults, they learn how to self-infuse. Now, as Milo pointed out, when he was exposed to this foreign protein, which his body is lacking, his immune system makes these antibodies, which then actually destroy whatever foreign protein is given. So we have to resort to using what are called bypassing agents, some completely different set of proteins to stop the bleeding. And in Milo's situation, unfortunately, we cannot give any kind of bypassing agent or this other protein to prevent bleeding. Whereas with Evan did not develop this antibody or this inhibitor, and so he could infuse, his parents initially and then him, could infuse these factor concentrates or factor product on a regular basis, and he used to do it at least 3 times a week, because once you infuse this protein into your body, it does not last very long. And so you have to do it 3 times a week, usually for day-to-day activities, so that you don't have joint and muscle bleeds. But if you're playing a sport, it's usually recommended you take additional doses of factor before practice and before games, which I know Evan was doing since he was an ardent swimmer.
Yeah. So let me ask you a couple of questions about that. Just from a practical basis, if you're talking about giving intravenous treatment, you have to put a catheter into a vein, which seems like itself could cause bleeding. So do your patients and did either of you guys have an indwelling catheter, something that was there all the time in your bloodstream that you could access to infuse this stuff?
Evan basically resorted to his own veins every time. So usually what happens is, since Evan was on prophylaxis 3 times a week, his mother learned how to give his medication through the IV by using what's called a butterfly. She was able to do this 3 times a week.
Just for our listeners, so a butterfly is basically just a very small needle goes directly into the vein.
Into the vein, that's correct.
Okay.
But with Milo, what happened is that since his bleeds, when they needed to be treated, the bypassing agent, since he could not use regular factor product, has a very short half-life, and he needed these injections intravenously every 2 to 3 hours sometimes, depending upon the type of bleed that needed to be treated. And so he actually had what's called a Mediport, which is a catheter, goes into one of the major veins in the body, and it's under the skin. So you basically access it by numbing it. You get good blood return, and that's how you introduce the bypassing agent into your body.
For patients for whom the factor doesn't generate this immunologic reaction, so for whom you can give these replacement infusions of the missing or dysfunctional protein, does that return the patient to normal? I mean, can people go about doing everyday activities and kind of eliminate the risk of bleeding?
Absolutely. A lot of our patients who are on prophylaxis, but it's one thing to do prophylaxis, recommend prophylaxis, I would say, and you have to be adherent, obviously, to the prophylaxis, and then you have, I would say, pretty much a normal life. Evan can, testify to that, doing most things that they want to do. And so we definitely encourage sports like swimming.
Non-contact sports.
Non-contact, lower bleeding risk, golf, tennis, those kind of sports, rather than playing soccer or American football, I think, is something we would absolutely say no to, because of head-butting and
obvious,
the risk of intracranial bleeding, which could be severe in somebody with hemophilia. So in general, I would say yes, they can participate in most activities that they really want to do.
It sounds like the first line of treatment is replacement. We've heard of this situation where sometimes that replacement therapy doesn't work. What's on the horizon for kind of fixing the underlying problem here? We've done a couple of shows on Well Said where we've talked about correcting errors in genes. We did a show some time ago about sickle cell anemia, and we had a guest not long ago who had a genetic form of blindness that responded to gene therapy. What's going on with the possibility for gene therapy for hemophilia?
Before going to gene therapy, I just want to point out that since 2017, we have what's called a non-factor product available to treat hemophilia. And the way this works is it kind of tricks the body into thinking there is factor VIII in your system, but it's this completely different antibody which binds to 2 other clotting proteins, producing what we call a clot to prevent bleeding. That has really taken off since 2017. Currently, both Evan and Milo are on that. Milo was on the clinical trial for this specific medication and did really well on it.
So Milo, tell us a little bit more about your experience with this non-factor agent.
It was really a lifesaver for me. With my condition, I hadn't had any medication or treatment really that sort of supplemented myself. So I was like everyone else, like my brother, who could perhaps do more sports and just sort of live like any child would. I mean, it was absolutely amazing. Once we heard about the study for it, we jumped right on it because, nothing else was working at the time.
How old were you at the time?
I must have been 12.
I think I forgot to ask you guys how old you are now.
So I'm 17 years old.
And Evan?
I'm 19.
19. Okay. So Milo, so it sounded like this was a game changer for you.
Oh my God, absolutely. It doesn't necessarily give you factors. So it's different than factor. Factor replacement therapy really is the ideal because it sort of does raise your factor levels. For me, the medication that I was taking at the time, it prevented bleeds, but it didn't actually do anything to stop bleeding within my body. Yeah. Mm-hmm. So I was still definitely at risk. I mean, it was night and day because before that I had 4 ports in my chest, and I was taking medication twice a day, once in the morning, once in the night. It took about 15 minutes for the past 7 years at that point. And this new medication, they told me I only had to take once a week. I mean, I didn't even need a vein for it really. Yeah. Which was an absolute game changer.
And did you say that, Evan, you started taking this other medication as well?
Yes, I did. It became approved, I think, later for patients without inhibitor. Yes, I am on this medication now. I think the great thing about it, like Milo said, is, it's not factor at the end of the day. It's not as good as factor, but it keeps us stable. It allows us to live, a pretty normal life without having to infuse so often, especially in the case of Milo, and just being able to navigate life a little easier because subcutaneous is going to be way easier than intravenous infusions.
So for you, even though you were able to take factor, this was just more convenient. Is that
100%? Yes.
Okay.
Especially as I've transitioned into adulthood. Now I'm in college. Yes, it saves a lot of time. It is very convenient.
Yeah. Before we go on to the gene therapy, I want to ask the doctor one other question about factor, which is in the olden days, the factor was actually harvested from patients, right? But now it's produced in a different way. Could you just talk about where the factor comes from?
Back, really, 50, 60 years ago, we used to use plasma, which contains all the clotting proteins, but you can imagine you have to give a lot of this plasma to increase your factor levels, right? Mm-hmm. And then there was something called cryoprecipitate, again, the same thing. And the biggest issue with both these products is that they transmitted viruses, and we saw that, in a hemophilia population, hepatitis C and HIV. So in the early 1990s is when factor was made in the laboratory, which we call recombinant factor products. That has gone through several generations of products. Initial recombinant products had a shorter half-life, which meant you had to infuse 2 to 3 times a week. Then sometime in the 2000s, when factor products with longer half-lives were manufactured, reducing the infusion to 1 to 2 times a week instead of 2 to 3 times a week. And most recently, actually, there's factor product for hemophilia A, which is intravenous, and it is factor, which is infused once a week. So, we've come a long way in terms of hemophilia treatment. And there are also 3 other non-factor products. In fact, there's one factor product where you can take it every other month. So 6 injections a year basically have a reduced bleeding risk and have a decent quality of life.
Just to be clear, none of those recombinant products have any of the risk of associated viral infections or contamination.
Absolutely. Yeah. Because they are made in the laboratory, not derived from the plasma of humans. Yeah.
Okay. So we only have a couple of minutes left, but I do want to touch on gene therapy as a possible cure for the underlying problem here, which is that there's a gene that's abnormal in some way, and that's responsible for the lack of or an abnormal kind of clotting protein. So tell us a little bit about the state of the art with regard to gene therapy for hemophilia.
So when you talk about gene therapy, it's basically using a virus to deliver a normal or functioning copy of the clotting factor 8 or 9 gene into the liver cell. So it's basically like an intravenous infusion, and this gene product homes into the liver. And then it instructs the body to make clotting proteins. And so technically speaking, it's a cure for hemophilia. However, the clinical trials that we've had have ranged in levels which are completely normal to high normal, and then there are patients have had levels which are much lower, which converts a severe patient into somebody with mild hemophilia. I think we still have ways to go about this, and there are 2 products that are approved, one for hemophilia A and one for hemophilia B in 2022 and 2023. gene therapy is really a dream come true for our hemophilia patients, but at the same time, I think we still need some tweaking in order to obtain totally normal levels, to sustain those normal levels so that patients in the future will not need any factor or any bypassing agent in order to prevent bleeding or even for procedures and things like that. Yeah.
Evan, Milo, are you looking forward to the day perhaps of getting gene therapy for your hemophilia?
Oh my gosh, absolutely. I mean, it's sort of hard to say all the experience that we've had throughout our lifetimes. And, even people who are older than us, how they've experienced, twice as much pain and experiences as we have. If there were ever a day where, we don't have to worry about that anymore, that's really like the end goal.
Yeah. Same for you?
100%. I'm super optimistic about it. I think the technology is incredibly cool. I think also, to my knowledge, it's being explored in other areas, and there's been other areas of medicine where success has been seen. And I think once it gets to a point where, I can confidently take it, I would love to.
Yeah.
I'd be totally on board with it.
Sure. Well, I'm going to give you guys the last word here. Anything else you'd like to share about your experience or information you'd like to share with families or patients with hemophilia?
I think diagnosing early is just really important. Hemophilia is a lifelong condition. It can cause a lot of damage, especially in females, actually. They're diagnosed way later in life. I think early diagnosis is extremely important in hemophilia. I hope to bring awareness to that.
I hope we've helped you do that today.
Yes, thank you so much for having us.
Thank you so much.
Yeah, it's been my pleasure. I thank you for being willing to share a little bit about your personal story. And thanks also to Dr. Suchitra Acharya, who is director of the Hemostasis and Thrombosis Center at Long Island Jewish Medical Center and head of the Bleeding Disorders and Thrombosis Program at Cohen Children's Medical Center. We've also been joined by two of her patients, Evan and Milo Cedeno. Thanks also to our editor, Edward Lee, our producer, Lois Bentavenia, and our audio engineer, John Mullen. For more information about this particular program and to find all of our past episodes, please visit our website at medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Our listeners are welcome to send their comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.